Hello, this is the presentation on the prevention of retained surgical items, which is a very important topic in the operating room. I'm sure you've seen your preceptors, your surgical tech in the room, perform surgical counts of disposable items, of instruments. So just kind of wanted to touch base on why this is so important. So first, what is a retained surgical item? A retained surgical item is any item that is left behind unintentionally during a surgical or other invasive procedure. It is considered a never event, which means it is something that should not happen if we are doing our due diligence like we should. This also means that if it does occur, that the hospital will not be reimbursed for any future care that the patient must obtain or for any care that we are providing for the patient. For any repeat surgical procedures to remove the retained item, it will be the responsibility of the hospital to pay for that themselves. It is 100% preventable, and it is actually the most common sentinel event reported to the Joint Commission. So there are about 2,000 to 4,000 cases of retained surgical items per year in the United States. This is considered to be grossly underreported because not all facilities, not all states require mandatory reporting of this, and it's obviously something you kind of don't want to tattle on to yourself. It is our duty to report when these incidences happen, but you might not work at a high quality facility like we have here in Kansas City, so it might not get reported as often as it should. The majority of retained items are found in the abdomen and pelvis. That's about 50% of our retained items. And then about 24% of retained items are located in the vagina. But also they have been reported in even small surgeries like eye surgery, ear surgery, and even in the nasal cavity. Risk factors for having a retained surgical item include incorrect counts, long procedures, if there's more than one procedure, so if a patient is having maybe multiple procedures at the same time. Also human factors like distractions, fatigue of the staff, failure to follow policy and procedure, any communication breakdowns, or even just simply inadequate education of staff. Patient factors also contribute to the risk for having a retained surgical item, such as a high BMI. If it's an emergent procedure, emergent procedures are actually 9 times more likely to have a retained surgical item. Also, unintended complications during a surgical procedure. If a procedure converts from laparoscopic to open, or if there's excessive bleeding, things like that can contribute to retained surgical items. This is important because it does cause harm to the patient, to the staff, and to the healthcare organization. For the patient, which is our most important focus, they could have extended pain because of a retained surgical item. They could develop an abscess, adhesions, fistulas, obstructions, could have a bowel perforation. They might have to have a reoperation, and they could even die from having a retained surgical item. Staff in the healthcare facility can also experience a second victim syndrome in which they could feel disbelief, anxiety, fear of this or fear of future events. It could be very anxiety provoking for them. And it also increases costs for everyone involved. There will be an additional length of stay in the hospital, additional procedure costs. There could be litigation or lawsuits. The facility could lose their accreditation. It has been shown that it's about a minimum of $200,000 per incident of retained surgical items. So for reporting, if you work in an accredited facility, you must report these retained surgical items to your accrediting body, your state entities, and often to the U.S. Food and Drug Administration. What items are countable? Well, we count a lot of different items, and it can kind of be defined to some extent by your policy, but there are basic items that every facility should count. Usually they are items that are x-ray detectable and that we consider small enough to be retained in, that have the potential to be retained inside a wound. So we count soft goods like laps, Ratex, peanuts, cottonoids. We count sharp items like blades, needles, or injectables, the cautery pencil, the little scratch pad. We count Fred, which I'm not sure if you've seen a laparoscopic procedure yet, but they have a little pad and a little bottle of this solution that they can rub onto laparoscopic instruments to prevent them from fogging up during surgery, and we call that Fred. Endo scissors, so on the tips of those laparoscopic instruments, there's a little tiny piece that screws on. It's disposable, one-time use, and it is just a scissor tip. We count those because they are small enough that they could be retained in the wound. And then we count instruments anytime there's an open procedure with a large incision. And then we count other items as outlined by our policy, like suture booties, vessel loops, things like that. And that is not a comprehensive list, but those are the basic things that we count. Like I said, sharps and soft goods, we count for every procedure. We count according to the number that the item is packaged in. So if it comes in a package of 5, like laps, we count them in multiples of 5. We see 1, 2, 3, 4, 5. 1, 2, 3, 4, 5 is 10. 1, 2, 3, 4, 5 is 15. Items should never be cut or altered during any surgical procedure. And we should always have communication of items that we use for packing during a procedure. So occasionally in big open abdominal cases, the surgeon will place a couple laps inside the abdomen, either behind retractors or to kind of control some bleeding. And anytime they're putting laps in the abdomen, you might hear your scrub tech say, hey, there's 2 laps in. And they're just having that communication with the circulator so that we know at the end of the case that there are 2 laps inside the patient and we need to go look for those before we start closing. All soft goods should be placed in these sponge holder counter bags. Hopefully you've seen these being utilized. So each bag has 10 little compartments. So if you're counting something small like Raytex, you will put 1 Raytech in each of these separate pockets. If you're counting laps, since they come in packages of 5, you rip the pocket in the middle and essentially creating just 1 large pocket. So then there would be 5 large pockets. Sponge counter bags, per AORN guidelines, should provide contrast to improve the visibility of sponges. So they should be like this with like a blue or an orange background, something where you can easily see the white sponges. We do instrument counts for cases when there's a likelihood that the instrument could be retained. And at North Kansas City, we kind of define that as any incision that's over 3 inches long. We generally try to count instruments. When we're in an open body cavity, we also utilize pre-printed count sheets to observe the count and to record it. Every instrument tray will come with a count sheet of what is in that tray. So we always go through it before we make any incision and make sure we have everything that's listed and the correct amount. If we add individual items to the sterile field, we will write those on a 1-by-1 basis and count those out separately at the end. We should be keeping all instruments in the room until the final count is complete. So standard procedure for counting is before a procedure to establish a baseline for our countable items in the room. Anytime we add new items to the sterile field, so if your surgical tech asks, can I have a pack of laps, and you open laps, they will count them out to you and you will add them to the count. Anytime we are having permanent relief, if you're going home for the day, even if you're going to lunch, you still want to do a quick count. Anytime any member of the surgical team requests a count, and I think this is very important. If you are observing the procedure and you as the circulator see that it's getting very complicated and there's just laps everywhere and you have very, crazy amount of laps on the field and you think, man, we need to get a count because we need to make sure we have everything, then ask for a count and you can by all means count. If it's a crazy time during the procedure, it might not be the best time to ask for a count, but if it's an appropriate time, then absolutely anybody can ask for a count at any time. We always want to perform a count when we are closing a cavity. So when closing first begins, when the wound closure begins, and when the skin closure begins, or at the end of the procedure. And that seems like a lot of counts, but not all those counts happen in the same procedure every time. If we're doing a quick carpal tunnel case, the incision is smaller than 3 inches, so we don't have to count instruments, and we actually only have to perform a first and a final count for that procedure. So that would only be a first before the baseline and a final at the end when the skin's closed. If we're doing a C-section, which we don't really do in the main OR, but they would do a count before the procedure. They would do a count when they start to close the uterus. They would do a count when they start to close the abdomen, and then they would do a count when they get on the skin. We must have visual and audible counting by 2 staff members. So both staff members don't have to be audible, but they do have to have communication and interact. So as you can see in that picture up there, Jason is doing the actual counting. He's touching the items he's scrubbed in, and Chris is visually looking at those items as Jason is counting them out loud, and then they are recording them on that whiteboard behind Chris. And so you can see the next item is we have to post the count in the room for staff, so that if you were to leave or you were to get relieved, that somebody could find that count quickly and know where it is located in the room. So what happens at the end of the procedure if the count is wrong? Well, first step is to recount. We don't always do everything right the first time, so we recount first. If we recount and the count is still incorrect, everybody in the room should stop the procedure and prioritize the missing item. So the surgeon should stop closing and assist in locating the missing item. Then we take action to locate the missing item. So first, those scrubbed in on the sterile field will search the wound. They will search the sterile field. The circulator will search the trash can, the periphery of the room. If it is still not located and you cannot find it in the room, we call for an X-ray, which must be read by a radiologist, ideally before the patient wakes up while they're still in the surgical suite. Once the item is found, then we will recount all of that item. So if you had a missing lap that you were looking for, you found it in the trash can, great, oh, I found the missing one. Then you have to perform a recount of all the laps to ensure that you are, once again, correct. As a side note, if you are opening and you are doing your counting and you're counting to establish a baseline before the procedure and the count is wrong, we should remove that item from the sterile field. So if you are doing Raytex, they come in packages of 10 and you count and there is 9 in your package. We take them off the sterile field and we open a new package that will hopefully have 10 in it. We count those. If there's 10, then we move on. And this is just to kind of also keep that standard of we should have things in certain amounts. So we always want to make sure that we're following that. Sometimes we do purposely leave items in a patient, so these are not considered retained surgical items. This would be items like packing, wound vac sponges, and implants. And while these are not considered retained surgical items, we still must document them and we still must take care so that they don't become a retained surgical item. And this is especially important for packing. Occasionally, surgeons will put 2 or 3 pieces of gauze into a wound, and it's our duty as the OR nurse to write exactly how many pieces of gauze they placed in the wound, because if we just say gauze packing, wound care might take care of that patient in a couple days, remove 2 pieces of gauze and say, well, that looks like it. But really there might have been 4 pieces of gauze in there. And so that can cause injury to the patient down the line. So having very good communication about exactly what we did in the OR is crucial. Right along with that communication, we always want to communicate counts with all members of the surgical team, make sure everybody's paying attention, everybody's focused, and everybody's on board with the count. If items are being placed in cavities, they should be documented. As I mentioned earlier, anytime laps are going into the abdomen, the scrub or the nurse scrubbed in on the field should say, 2 laps in the abdomen, and the circulator will make note of that off the field. We want to document all the counts that we perform and any discrepancies in the patient's medical record. AORN also came out this year and formally recommended the use of adjunct technologies to prevent retained surgical items. So I just wanted to briefly mention the future of surgical counting in the OR. So there are three main companies right now, Medtronic, Stryker, and STERIS, that have different equipment that assists with detecting sponges. So right now, most of them only do laps, Ratex, a couple of them do cottonoids, but they have little RFID tags in each of the surgical sponges. And each of these three companies do it a little bit different, but they have equipment that can detect the RFID tags on these surgical sponges. So before the procedure, you will count in all your sponges, and at the end of the procedure, you will use this equipment to verify your count. The Medtronic equipment does not verify any counting. It simply detects if there's a sponge. When you're waving, it has a little wand, and it can detect if there's a sponge in the wand's range. So it works a little bit differently, but I will post all of these if it's something that's interesting to you or something you just kind of want to see. I think the Medtronic one, like I said, does not count any of the sponges. It simply just is a detection tool. So if you have an incorrect count and you say, oh, where's the sponge? You can take the wand and you can wave it in front of the trash. You can put a sterile drape on it and wave it over the patient on the sterile field, and it will locate the sponge that is missing. Stryker SurgiCount and the STERIS OR Locate are both items that actually do count your sponges in and out, and also have detection wands that can find a lost sponge. So they're pretty cool. We don't have this at North Kansas City Hospital right now. We have actually talked with all of these companies in hopes that maybe in the future that this could be something that we would work towards. And these, like I said, are the only three companies that have this technology right now. So I'm sure others will do it in the future. But it is kind of cool to look at. And if you're going to pick one video to watch, I think the STERIS one is kind of the most interesting. But I don't work for STERIS, I don't work for Stryker or Medtronic, so you can take your pick. I have no preference, but I think that the STERIS one is the coolest. Here are the references that I used to help me make this presentation. If you have any questions on retained surgical items or counting, please don't hesitate to reach out and let me know.